Hi, everyone. Today is my Women's Health series on pelvic floor dysfunction. So this is an important topic because what we are seeing is a lot more women than you would expect actually have pelvic floor dysfunction. Who are the most common women to have this? It's pregnant women after they have the baby, and also postmenopausally, intriguingly, a lot of women complain of pelvic floor dysfunction. When we think about the pelvic floor, it is the muscles that act like a sling. Every organ in your body sits on the pelvic floor, and the pelvic floor is carrying every organ below the diaphragm. So heart and lung above the diaphragm, getting carried by the diaphragm, but everything below the diaphragm to the pelvis is carried by the pelvic floor. The pelvic floor allows very good control of bowel and bladder. How do we get this dysfunction? Well, vaginal childbirth actually can cause an issue because we're going to have the vagina go from what starts out as a pencil opening to an opening large enough to let that baby out. So that's a huge change. And so these muscles really have to accommodate that. Who else are at risk? People who have things like bicycle accidents, horseback riding accidents, they fall skiing, all this when I land on my pelvis, because when we look at the muscles of the pelvic floor, we will see that piriformis and these muscles called pucococcygeus, which can really take a big beating when you land poorly, can then have impact. But not everyone who falls, not everyone who has childbirth, not every postmenopausal woman has this. So they don't understand why some people have it and some people don't. When women come to you, or people who have this issue, you want to say, are you voiding your bowel completely when you're having a bowel movement? What some women, and then a few men, but it's more a woman problem than a man problem, although some men have it, they're going to say, I go, but then I feel like I have to go again in only a little bit of time because they're not having complete clearing from the rectum. And then they're going to start straining. Straining is not helpful because then what can happen is I can get hemorrhoids and I can get bleeding, and that's not so great. So you don't really want to be straining. You want to make sure that you can have a really easy bowel movement. The big thing that my women patients would come in complaining about is this either frequent need to urinate or what they call stress incontinence. Now I'm losing control when I cough or I sneeze or I laugh or something's happening. And I'm having a lot of trouble either starting or stopping the flow. And so I don't really have a really good control of urination. And that can be embarrassing for women and uncomfortable for women. And then I think this happens more in older men, that they also then have pelvic floor issues that's leading to also some stress incontinence and could come on after a prostate problem. So the other problem that women come to me and complain about is pain during intercourse. And that is because, especially as women age, that pelvic floor can be like an older rubber band. It's not as supple as it once was. So we're going to talk about some things that women can do to keep that area a lot more supple so that that is not as painful. And we don't want them to come in and complain that they have all this pelvic pain. And we don't want them to have all this other lower back pain. The problem is that when I'm looking at the pelvic floor, there are the gluteus maximus muscles are making up part of the pelvic floor, the piriformis. And when that pelvis gets a rotation, then my low back can try to compensate. And sometimes what I found is if I adjust the pubic bone, or we're going to do a bunch of positional release therapy that the patient can also do, what can happen is that the low back pain completely goes away because it really was their pelvis. So let's take a look at this. This is a female pelvis here. And so when we look at the pelvic floor, we have to really be amazed at just how much is going on in here. Here is the pelvis, as we are all aware that's on this call. And we can see here that this is the base of the sacrum. Now, from the sacrum, we notice that we have these two piriformis muscles that are going out to the femur. When these muscles have all this weight in here and there's any kind of problem with the pelvic floor, what can happen is that the piriformis can really get very, very tight because it's really trying to hold this in place. A lot of women will complain of a lot of pain on the insertion of their piriformis on their trochanters. The other possibility is that when we look at the design of this pelvic floor, what we see is that we're seeing that this is a really important muscle here called, and there's one below it called pubicococcygeus. It's going to attach right near the pubic ramus here, and this is a disc. And this can start to degenerate as women age or men age. And then I don't have a really good alignment of the symphysis pubis, which is an attachment to this very sling-like muscle here, which again, in women, we're going to see has 3 openings, one for the urethra, one for the vagina, and one for the rectum. So then we'll see that in a minute on another slide. And again, if I'm carrying a baby, all of that baby is sitting right in here. And what's going to have to happen is that these ligaments are going to have to relax so that that sacrum can move back and forward in childbirth to let that baby out. So we're going to start with a very small opening. It's going to have to open to 10 centimeters. So let's look at it from the side so we really understand why we're getting bladder and bowel issues, especially with pregnancy or post-pregnancy issues. Here we have this great idea. Let's put a sling from the coccyx right up to the pubic bone. We're going to have an opening for the urethra from the urinary bladder. We're going to have an opening for the vagina to the uterus, and we're going to have an opening from the descending colon through the rectum to the anus. That's 1, 2, 3 openings in a muscle that is a sling. That's why women have more issues than men, because now we have 3 things happening there, whereas men only have 2. Additionally, the non-pregnant uterus is the size of a woman's fist, which is the same size as her heart. But you're going to put 6, 7, 8, 9 pounds in there, and this uterus is going to then be pushing on the descending colon, but especially the rectum, but also that's if it's more leaning back, but it's also going to push on the urinary bladder. And so what's going to happen is the urinary bladder can't fill as much. The weight of that baby is going to make you feel like you got to go, you got to go, you got to go. And again, when now I cough or I sneeze, and now I'm pushing down the urinary bladder, when I look at the urethra, there's both an involuntary and voluntary sphincter there, and I can overwhelm the voluntary sphincter because now I'm just squishing out that the urinary bladder. I'm just going to cause that urine to just flow out because, again, just a sling there. So the other important thing to remember is that the lungs, which are above the diaphragm, and the heart, that's going to be supported by the diaphragm. But everything from the diaphragm all the way down to the pelvis is sitting in here. That means that these other supporting muscles of the back are going to have to work really hard if the sling is not working. Who are those muscles that are going to work really hard? This muscle right here is psoas. And so this is iliacus. So the iliopsoas muscle, which goes to the lesser trochanter, is going to have to work very, very hard. And remember, we saw that piriformis going from the sacrum to the greater trochanter. This is why some women get a lot of hip symptoms, because now I have this muscle working really hard to hold things in place. this muscle working really hard to hold things in place. And so this is why we really want women to do really good hip exercises, whether they're doing squats or they're doing lunges, or they're doing some kind of exercise where they're keeping really good hip mobility, so that we can make sure that psoas and that piriformis are well and balanced, or that's going to cause a lot of stress here. This inguinal ligament is the lower edge of the abdominal muscle. If I am pregnant, so I've put on a lot of gain in that area in my abdomen, and there's a lot of stretch, that's going to put a lot of pressure on this inguinal ligament. And the nerves are exiting from the sacrum through that, under that, over the psoas, down the leg. And this is why some women will feel that they get this numbness and tingling in their thighs because of this pressure when I start to either gain some weight, or I'm having trouble losing that baby weight, or just the weight of the baby itself. This muscle here, quadratus lumborum, is where you get a lot of pain when the psoas is weak. The psoas is attaching to the anterior aspects of L1 through L5, and quadratus lumborum is attaching sort of on the back, sort of from that rib right to the superior portion of the iliac crest. So now what's happening is that this is working really, really hard if this is not working well. These are the women who, if they lie on their back, they can't even really pick their leg up because their psoas is so weak. They'll have a lot of low back pain. And then the way the baby sits, as the baby is growing bigger and bigger in this area, it could really be sitting back labor. And some women have horrible back labor when they're having that, because that baby is kind of laying there and pushing on that QL. And so this is why when we sometimes fix the pelvic floor, a lot of their QL pain goes away, their psoas pain goes away, their hip pain goes away, and we really have a great results. Reason that you can't lie on your back when you're as pregnant as you're about to have the baby is because you have this, your inferior vena cava in there, and this, your aorta, that's going to break into those two common iliacs. If the baby lays on that, it will actually collapse the inferior vena cava and it will wake you up in the middle of the night. I do remember after giving birth, I was like, whoa, I can lie on my back again. And that's why you can't lie on your back, because you're just going to crush that inferior vena cava, just the weight of the baby. It's going to wake you up right away because you're not getting good venous return. This is why it's so critically important. There's only 3 things that let the blood back to your heart, and that is your skeletal muscle pump in your legs. So you have to move your legs all the time. Sitting, not so great. You want to keep pumping your legs while you're sitting. You have to breathe with your diaphragm. You want to take nice deep breaths because you get a negative pressure that will suck this up. And the only other thing is your sympathetic nervous system. And so you can start to feel a bit stressed out if you are getting pressure on that inferior vena cava. So what we want to do when we're looking for ourselves or our patients is to look at all these painful insertions of all the muscles that attach to the pubic bone. So when we're looking at the pubic bone, there's a lot of muscles that are attaching there. One is this, the rectus abdominis. So when we gain some weight or when we're pregnant, the rectus abdominis has to really stretch, but it is attaching to the superior ramus of your pubic bone. And so if this is not working good, it's putting a lot of pressure on everybody else that's attaching there. If we look at a lot of women and you run your hand up this inside of the leg, which is called gracilis, that can be very, very tender on women. This adductor longus can be so very tender there. And then in this muscle here, this little pectineus. So these 3 muscles are really important to look at as we're working on them, because the way that they're attaching, if I've strained these, would be if you like ice skaters, they get a groin pull. Another group of people have this. And this is a disc. And this can be adjusted, and that can give a lot of relief to this when we have a problem here at the insertion. And then when we look here at the back, I just want to point out that the latissimus dorsi, which is a shoulder muscle and lets you reach above your head, it has all of this ligamentous attachment to the sacrum. And sometimes you can even find, because this is so locked up with all that's going on in the pelvis, that you can start to have shoulder pain because now the lat is getting so tightly tucked at the bottom. When you go to lift your arm up, you just feel like you can't raise it. And that's truthfully, you get this really bad point right here. This is a latissimus dorsi trigger point, and you're just going to want that rubbed out because really the lat is not working for you and it lets you lift over your head. And I tend to work a lot also on the obliques because of the way that they're going right along that inguinal ligament. My favorite book for this is called Positional Release Therapy by Ambrosio and Roth. They are a physical therapist and a chiropractor. This book has been in the market a very long time. You can buy it for not a lot of money. I love this book. I put a lot of pictures in here from this because what I want you to see is that I'm going to put the page numbers that they are, but I actually did pictures of it. When you look and see these are probably two of the most common muscles that I have worked on when people have a pelvic floor issue that's causing their low back pain. That really helps a lot on working on this pectineus and the adductors. So here is an interesting point that I've worked on lots and lots of people, and that is this called the obturator externus and pectineus. So we just saw, let's go back there so you can see what I'm saying. This is this little muscle here going from the inferior ramus here over to the lateral thigh, and can be very, very tender to the touch. What happens is that you just find the spot right over here in the obturator, these little hole areas there. And what you see is when this point is very sore, we can all check it on ourselves, find that spot, push on it on the left and the right. If it is sore, it'll tell you the tender point is on the lateral surface of the body of the pubic bone. That's right here on the medial margin of this, the obturator foramen. You're going to push medially towards the pubic symphysis here. The doctor or a friend or by yourself, you can do this. What I have done is put my leg up on a chair. You put the side that's painful with your knee about 90 degrees on a chair, and then cross the other leg over. You can use your own finger, or the doctor uses a finger and stands on the side and pushes it in towards this point. What you do is you then internally or externally rotate this bottom leg until the pain under your hand goes away. And it says, no, a physical therapy ball or chair can be used. Yes, I have done this on myself. And then I just have to move this in and out until the pain goes away. You hold it for exactly 1 minute. Set your phone, and then it dings. And then you stop the position, you carefully unravel yourself, and you'll notice, wow, this spot isn't sore anymore. And you can do this once a day. I have the patients do this once a day before they go to sleep so that they're resting, and that will help a lot when the pectineus is the issue. These are the women, they have a lot of pain. If you try to rub up the inside of their leg, they're like, oh my Lord, that is so sore. And then you find up by that LBP point for the lateral pubis, very sore, you can do this. The adductor, which is this here, and that's attaching here at the bottom. It says right over here where it is, and you can see those painful points. This one, what you can do if you're trying to do this at home by yourself, this is a little harder. This is better by having somebody else help you, because the doctor again is going to push on this point here right along whichever is more sore, and then you're going to keep moving that leg like it says, and you move the extended knee. That's what's important. And you're going to just kind of bring it over until this doesn't hurt anymore. Have I been able to do this on myself? Sort of. If you put a bit of a pillow and then try to bring your leg over and then hold it there so that the pain under there is less, you can try that. if somebody else does it, it is a little bit easier and you're waiting for that pain to go away. But again, setting the timer exactly 1 minute. The mechanism is believed to be that what's happening at the insertion of these muscles where these painful points are, is that there's a specialized neurological organ in the tendon called the Golgi tendon organ. It tells the weight on the muscle, and somehow it's getting the wrong weight registered with it. And somehow by holding it in a mechanism not understood by me, that when you hold it for a whole minute, it's like flipping the circuit breaker. It just lets the body know that the weight is now correct, and now all of a sudden it gets better. And again, can happen in men. They had a bicycle accident, they fell, something, groin pull, they're an ice skater, they're skating, they're doing something like that. I have definitely worked on men with adductor issues. Now, the rear view, when there are all these ligaments, and this I show my patients, why we have so much ligament laxity post having the baby, and why we have to do non-force adjustments after the baby, is that when we look at this right over here, what we see is that these ligaments are going to get a lot looser. But ligaments are like adhesive tape. When they're looser, they're not going to hold these bones quite as stably in place. Now I just move the right way and I literally pinch a little piece of the ligament in this sacroiliac joint. That is so painful. Now you can't sit. You're like, oh my Lord, I can't lie on my side. It's just so painful. That really responds really well to ice massage or pulsed ultrasound, provided you're not pregnant. But if you are pregnant, this is really great to do ice massage. You just take an ice cube and then you just massage the whole area, cool it down, and get that ligament to tighten back up, especially in a back labor. So great. Do some ice massage because it can be really quite painful with these ligaments that have to relax. And again, here's that pubic symphysis, and that can be adjusted. And then look at all of these ligaments, why you can get a lot of hip pain in this problem. So you find the tender spot, and they are all of these PS 1, 2, 3, 4, and the coccyx. And then this is a great picture where you really see what the design truly looks like when we're looking at this. My favorite, this one here, pubicococcygeus. I do a lot of work and have patients do a lot of work on pubicococcygeus because it's going to come right here, right next to the pubic symphysis. It's going to come right around here, and then it's going to go back here and attach onto the coccyx. And it has to have those 3 openings. And so what we're going to have to do when you have the baby, this opening is going to have to open to 10 centimeters. So you can only imagine the stress that that's going to put on this pelvic floor. And so again, we have on the front one, we have the urethra, then the vagina, and then the anus. So a lot of stress there. So let's say that PS1, these points here are really sore. This you do need help with. You find that sore spot on the sacral sulcus, and what you're going to do is pressure is going to be applied straight forward. The patient is on their belly, can't do this pregnant unless you're on a special table or you have all kinds of support. But I did figure out a way to do this on a pregnant woman by just literally having them sort of stand up and then do it while they're standing, and they can brace themselves so the baby's not getting pushed onto like the wall, but you can do a little forward pressure here. And then what you're going to do is while you're pushing that, it says you're going to also then be on this angle and kind of move that, gently rotating around an oblique axis. What is the point? You can't really hurt anybody with positional release therapy. You're going to keep moving things around until the pain under the point of PS1 or 2 or 3 or 4 goes away. Once the patient or the person that you're working on, or even on yourself, once the pain goes away, then you hold that position for 1 whole minute. That seems to get rid of the pain. And again, you could do it every day if you have to. And so you can just see they're just doing this same thing. Patient is prone, anterior pressure. You're just going to do some kind of rotation until this point is not sore. That's the whole point. You're just holding that Golgi tendon organ. It seems to be why it's working on the ligament. I'm not clear about. But again, it seems to be a load issue. The body thinks that the weight on this is misset, and somehow you're resetting it. And so you can just see these are all sort of the same thing. Find the spot, do what kind of rotation move that you have to do. And it says, again, you can use pillows to support the patient's trunk so that you can keep this leg a little bit in extension. And these are all 1, 2, 3 in a row. And I put it in the presentation, and I'm videotaping this. Hopefully I definitely see the record button. And so we'll have this up, and that way you can see this, and then you can email me and I'll just send you the presentation so they have this from the book. Although I love the book. So then I put the most common muscles that I've worked on over and over. And I like to have this picture to show patients because it's really interesting for the patient who just never thinks about this. They've seen skeletons at Halloween. They see that nothing is there, but it doesn't occur to them that that baby, that their intestines, their bladder, all of those things, the uterus, everybody is sitting in this. And look at this. Here's piriformis, why it can be so tender. It is the pelvic floor. And then here is that really cool pubicococcygeus muscle going from the pubic bone all the way here to the coccyx and the lower sacrum. So it's a really cool muscle. And then we have these other sideways ones. So it's really quite the whole sling idea. So this is my favorite one to have patients do for themselves because it's super easy to do. You find, and everybody can check this on themselves, it's on the call tonight, find the superior ramus of your pubic bone on the right side or the left side. And when you have a problem, it will be very, very sore. And what you do is you hold it. Instead of having the therapist, you have the patient, I can do this on myself, put their hand behind their thigh so that they're not putting too much pressure on their knee. You're going to bring your leg up, and you can do this lying down. You can do this standing up. You just find that spot, you bring your leg up, and what you're going to find is there's going to be a point where that point is totally not sore. You may have to move the knee a little bit in or a little bit out. Pushing straight to the back while you're doing this. Lying down is great, but I have done this at the office when I've just been in trouble and literally stood up, brought my knee up, and just put my foot on the table, leaned in, pushed on the spot until I actually could feel that sling relax. And then you hold again for 1 minute, and it says, see, 90 to 120. So they say don't move it in or out. But on some patients, for whatever reason, they feel a little teeny bit better if it's slightly in or slightly out, but try straight up and works like a charm. And this is going to get rid of a lot of stress incontinence. I feel like this is the muscle that is that problem where you're feeling like you're not having good control, because it is very important in what is called the external sphincters. So these are the ones you have conscious control over. This is the other one. This is the one that's more lower here. If you see this, iliococcygeus, that's this one right here, that sideways sling one. That's going to be underneath. That's why the therapist is doing this. Again, you can do this yourself. You kind of find the sore spot that's under here. You do kind of a baby pose in yoga where you grab your heel and pull your heel up until this doesn't hurt anymore. Again, wait 1 minute. That's going to reset the weight on that. It could be sore on both sides, just like the one that we just did before. Pubicococcygeus could be sore on both sides. It's very important to do only one side at a time. That seems to work much better. And then this one is this sacrotuberous ligament. I use the sacrotuberous ligament all the time. I was adjusting a baby today, and I just held the sacrotuberous ligament, and you just find on the baby. So when you're adjusting a little kid, you just go down along this line here until either this or this makes the baby make this kind of funny little move. And that's where you're going to connect on that sacrotuberous ligament. And then it shows here, you're just going to hold that, and then you can move the leg. So this you do kind of need somebody else to help you with. And again, can't do this lying face down while you have the baby, but I have figured out on pregnant women to have them stand, kind of brace themselves on the wall, and then I can hold the spot and have them move their leg until the pain goes away, holds 1 minute, and then get a lot of relief on this sacrotuberous ligament, which is really going to work very, very hard in childbirth. So then piriformis is tender on so many women. And so when we look at piriformis, there are 2 spots for it. One is right in the center of the muscle, but one is at the insertion. I will say that I have so many women and men patients have piriformis issues. It's sometimes really painful to do piriformis work on people. And the beauty about positional release therapy is just how much easier it is to do, because you're going to the point where the pain goes away instead of doing something like ART or doing Graston or something where it could be really painful. Not to say that's not good, but I think when you have something where you're really getting relief, it's really nice. Can you do this? One's hard because you kind of have to have your leg off the table to do yourself, but this one you can if you put your leg on pillows or on a physio ball or something like that, so that you can lift that leg while you're pushing on that lateral right here where the piriformis is attaching to your leg. Again, so tender on so many people. This is an exercise I'll send them to do at home. Put some pillows here, get that leg up, push that, maybe figure out where you have to get the leg, how high or low it has to be so the pain will go away. But it does go away. That's so cool. All right. And it just says that it can roll it to produce a little bit of external rotation. So you can see how her foot is toe out. And that makes a really big difference. Here you got to do a bit more where you have to, where it says fine tune the position. Yes. That really makes a difference, where you're just holding the point and gently rocking at that last little couple of inches until the pain is a lot less. Then you're at the right spot. Then you hold it for a whole minute. Makes a massive difference. And again, no problem doing this every day until the pain just seems to go away. This is this other one that we saw, this gemella muscle. This is going to go, this is a lot of when I have a lot of posterior pain that is coming from my pelvis. You can do this point. On this one, you can see they're putting it up there. Again, some of these posterior points you really need somebody to help you with. And I cannot stress enough that there's going to be a little bit, even though you say, oh, I want to look exactly like the picture, the most important thing is to be on the right spot. And then keep moving the leg until the pain goes away. Even if it doesn't look 100% like the picture, when it goes away, that's how you know that you're going to make a difference. And then you set the timer for 1 minute. The other way that you can work on this is Travell and Simon's trigger point work. I have also done a lot of trigger point therapy for people in addition. So this is the patient who's going to come in and they have a lot of pain right at the rectum and down the back of their leg. And what that tends to be is this obturator internus, this one here. And what happens is that this is a tough spot to get to this is why if they have this pain and you see these X's and you look over here, you want to kind of see what these other spots are that you could work on, because that may be the other thing that's causing this pain, because it's really a sling issue and it's really hard to get to those trigger points. Impossible actually, but if we see this pain pattern, we're like, oh, that is pelvic floor. If I see this pain pattern on the leg where the patient is complaining, it just feels really bad. It looks almost like it's sartorius. It looks like it's coming from the thigh to the knee. And yet, truthfully, it's pectineus. And this is going to make a big difference when you're more on that medial thigh. And what you do is you can just do cross friction massage on those two X's. What you want to think about the muscle fibers is they're like clay. And if you had clay and you wanted to lengthen, you would go across at 90-degree angles and roll it, and then the clay would roll out. That seems to be why Janet Travell's cross-friction massage seems to work so well. They'll be quite tender, but you're just going to roll it and rock it and kind of picture this lengthening. And then a lot of times what you find is all of a sudden this pain, then these are two really intense spots of pain that you can have. And this pattern would really be these two X's. So it's, I want to show you this because this is one of my favorite places that you can go to. This is a trigger point guide. You can click anywhere on this. So say a patient comes and they're like, this is the place that's sore. You just click it and then it tells you all the possible muscles that it can be. So let's say that you have this sort of anterior knee pain here. I just click it. It will tell me every single muscle that's going to put pain to the knee. And instead of keeping on working on the knee, I'm going to rub back and forth on the X here, or I'm going to rub back and forth on the X here, or these. And the knee pain is not from the knee. That's not the issue. It's really these other muscles that you're seeing the X. So this is the X on the skin. This is where we're seeing it on the muscle. Again, you're just feeling around for that, and you're going to see how the muscle runs, and you're going to go at 90-degree angles 30 times. Not too hard, but thinking about like it was clay and that you're rocking it, getting it to lie flatter. That's the key. And so this is a great thing. It's triggerpoints.net. When I owned Janet Travell and Simon's book, it was $300 to buy the book. And now it's all on the internet, which is so exciting and so great. So this is a case that I had. I had a 76-year-old woman come to my office. This is how I got involved with this whole book. And she had this non-specific low back pain, and I was trying everything. And she'd gone to physical therapy, and she just had so much groin pain. She wasn't able to walk. She'd been in a wheelchair for a month. And so that meant I had to figure out something, because she'd had a lot of other problems. And because she wasn't emptying her bladder well, she was getting multiple urinary tract infections that ended up leading to interstitial cystitis. And it had come on the first time after she had a baby, but that had, of course, been a lot of years ago because she was already in her 70s, right? So super interesting, but she was having a little bit of irritable bowel too, because now that wasn't emptying as well as it could be. She did get some relief when she had acupuncture, and also she was much worse lying on her right side. So she was waking up with 8 out of 10 in the morning, and by the afternoon, she was feeling a little bit better. But basically, the morning was the worst. So what I did was intriguingly normal range of motion, but everything was stiff. When I checked every single muscle for pain or weakness, her right rectus abdominis was very weak, her right adductor was really weak, and then she had pain at pubicococcygeus at the adductor point and the PS1 for the short posterior sacroiliac ligament. So what I did was I did PRT, started with pubicococcygeus. I had her do it at home. I also did do some gua sha and ultrasound to her adductor. My patients really like that. What you have to do, it's really important, gua sha or any instrument assisted, Connect-X, whatever you want to call it. Very important, put arnica on first. then lotion. We're going to show you a gua sha tool. People can totally do this at home. And what you can do instead of ultrasound at home is you can gua sha and then do ice massage. Works almost as well as the pulse ultrasound because it acts like ice. And then I also did the PRT to SS1 and a little bit of massage. I did adjust her as well. And when you have low back problems, you always have compensatory neck problems. So whatever you find in the low back, you just count where occiput goes with the sacrum and then C1 goes with L5 and like that. And so you always just pick what's called the love it brother. And then the way I adjust the pubic bone, I had the patient lie on their back, put their feet directly on the table. I push out on their knees and they push in. They're pushing in with all their might. And then you quickly push their knees apart and we'll readjust the pubic bone. Worked really good. And then of course I did do right hip, knee, ankle, and foot, because got to do the whole leg. That's part of the problem. So one of the things that I figured out was that it was really important for the patient to do PRT at home. So I showed her because I felt like the main muscle was pubicococcygeus, and because I've had the most results, especially for urinary problems with pubicococcygeus. That's the one I have everybody do at home. And so I gave her the printout at the time. Now you can just have them do a phone picture of it. I made sure that she understood how to do it. Then I gave her the whole thing about Travell and Simon's trigger point on the adductor, and I had her get a gua sha tool, which you can buy on Amazon. They come all different kinds. This happens to be a jade one, but you can buy, there's bone, there's plastic, there's all kinds of things, there's metal, whatever you feel like doing it. And I told her to do both things at night before bed every other day. And then I wanted her to also do wall sits. And I think I had a YouTube video about wall sits. I really love wall sits. Or no, this is a gua sha. This is a gua sha video. So I put it on there, but you can just do gua sha and show them how to do gua sha. So I put a gua sha video, but just type that in. Now there is wall sits. I thought that was what this was. I forgot this was the gua sha. Wall sits has really excellent things also on YouTube. And I do not like people doing sit-ups. I think it's really, they always pull too much with their neck. And I find wall sits work way, way better. And I make them practice in the office to really get that good pelvic tilt. And that also seems to help strengthen that whole area for the rectus abdominis. This is what I show them. These are all our possible gua sha tools that you can buy on Amazon. They're really, really reasonable. However, when they did a study at the college, when they use this, the Connect X, or they use Graston tools, the stainless steel ones, they found everybody bruised. I find no one bruises if you do some kind of arnica gel first. So you're going to put the arnica gel on first, which you can buy anywhere. And then you put on regular lotion and then you use the tool. The thing about the gua sha is you want to go up and then down, then right, then left. And that's why I put the video on there so that it's really helpful for the patients to see how to do it. And then once you watch it, it really comes out great. And then they can do it every other day. The patient got so much better. With only a couple of visits, their pain was down to 1 out of 10, and then they were able to come in regularly. And then every time the pain came on, they were able to take care of it themselves, which was really exciting and really helped them have a lot of relief between appointments.